This systolic ejection murmur reflects turbulent flow across the stenotic aortic valve. In contrast to an innocent murmur, this murmur peaks late in systole. Notice the late peaking of this murmur. Innocent murmurs reflect a normal flow velocity profile across the aortic valve. Aortic stenosis, on the other hand, has a delayed peak, reflecting the increased obstruction to outflow. Notice how the innocent murmur peaks early in systole, and compare that to the late peaking of aortic stenosis. First, the innocent murmur, and now aortic stenosis. The presence of an ejection click localizes the obstruction to the valvular level and strongly suggests the presence of a bicuspid aortic valve. I will begin with normal heart sounds and then add the ejection click and then the murmur of aortic stenosis. Pathologic murmurs secondary to obstruction across the left ventricular outflow tract can occur at the subvalvular, valvular, or even supravalvular level. Notice the ejection click that initiates this murmur. With significant aortic stenosis, the carotid upstroke may be both delayed and diminished. The murmur of aortic stenosis will, on occasion, be audible at the cardiac apex with a change in pitch, the Gallavardin phenomenon. Despite this increase in pitch, this murmur retains its characteristic diamond shape. Listen to this murmur first at the second right intercostal space, and now at the apex. Although stress testing is contraindicated in symptomatic patients with aortic stenosis, it has been safely performed in asymptomatic patients. As many as 1/3 of asymptomatic patients will demonstrate symptoms or abnormalities on exercise testing that may warrant valve replacement. Listen to a patient with combined aortic stenosis and regurgitation. I will begin with the systolic murmur and then add the diastolic component. Patients with aortic stenosis and a low ejection fraction are problematic. One way to identify those patients who will respond well to surgery is pharmacologic stress testing. If their gradient increases significantly with dobutamine infusion, then these patients are acceptable candidates for surgery. Listen to a patient with aortic stenosis and both a third and a fourth heart sound. I will begin with the fourth heart sound, then add the third sound, and finally the murmur. Recently, percutaneous aortic valve replacement has been introduced. Clinical trials, still in progress, will reveal the indications and benefits of this exciting new approach to aortic valve replacement. Echo Doppler studies can define valve anatomy and function, allowing a calculation of both valve gradient as well as valve area. In summary, aortic stenosis usually presents with a late peaking, diamond-shaped murmur heard best at the second right intercostal space. When this murmur is accompanied by an ejection click, it suggests a bicuspid aortic valve. Listen once again to the murmur of combined aortic stenosis and regurgitation.